we finally have the new 2018 Nomogram classification that is related to the treatment with intrastromal rings for keratoconus. The philosophy of the new Nomogram classification states that each keratoconus is unique and therefore should be assessed individually and systematized to define the best and most appropriate surgical approach, subsequently produce a detailed analysis of multiple topographic, refractive, visual, and aberrometric variables that are all essential to create a good plan of surgery to satisfy both the surgeon and the patient. There are many available intrastromal rings today, and the parameters that distinguish them from each other are basically the diameter, arc, and thickness. For what concerns the diameter, we have the possibility to choose between a diameter of 5 mm and 6 mm, and this choice is dictated by the mesopic conditions of the patient's pupil so as not to create too many nocturnal aberrations and halos around lights. The second parameter is the arc, that is how many degrees the arc extends the ring, and we have an initial parameter that is of 90 degrees, then 120 degrees, 150 degrees, or 160 degrees that are in accordance to the optical zone. We may also go to the less common choice of 210 degrees, and finally the 325 degrees arc, which is classified as a 5 mm ring even if in reality it has a diameter of 5.7 mm and therefore is an intermediate condition. To these variables, we add a third one, which is the thickness of the rings that varies from 150 to 350 microns with a pitch of 50 microns, so practically for each of those we mentioned before, there is the 5mm and 6mm version with arcs of 90 degrees, 120 degrees, 160 degrees, 210 degrees, and 325 degrees, and for each, there is a specific thickness available. These determine how much correction we are going to make with the intrastromal ring and how difficult it is to choose the appropriate one to correct our keratoconus. A new challenge has recently been added. A new variable that is of the possibility of having asymmetric rings is now another difficulty, and it is born from the fact that keratoconus is a disease in which by definition the cornea takes on asymmetric appearance, but in its asymmetry, it is usually symmetrical, and this means that the deformation of the cornea usually has a symmetrical pattern and is therefore corrected quite well with a variable thickness ring. However, this does not happen if there is a corneal deformation of an asymmetric type, and later we will see which are the most common characteristics of asymmetric keratoconus. Here, we have the need to create asymmetric intrastromal rings that have a variable pitch and begin on one side with a specific thickness and a different amount of thickness on the other end. These types of rings are luckily available only in the arc version of 150 degrees for 6 mm and 160 degrees of 5 mm, so all the other ones are inaccessible, 122, 210, etc., and are difficult, in addition to the fact that this increase in thickness may be clockwise or counterclockwise. What we have is the clockwise version that has an increase in thickness of the ring in the clockwise direction, and the anti-clockwise version that has an increase in thickness of the ring in contrast to the clockwise direction. The new version of the asymmetrical ring 330 degrees is added to the asymmetrical ones. It is also 5 mm, therefore its optical area is 5 mm, even if it's actually 5.7 mm, and the characteristic of this ring is increased thickness, moving from 150 to 250 or from 200 to 300 in the AS5 330 degrees version, thinner at the tips, thicker at the center of the arc. The later version is the variable ring with sinusoidal thickness and an arc that is always at 330 degrees is in the versions of 150, 250, 150, or 200, 300, 200. It has a sinusoidal or inverted profile and can be thin at the tips and at the center of the arc and thick at the intermediate portions, or thick at the tips and center of the arc and thin at the intermediate portions. With this, we can see how the correction of nipple cone keratoconus with central ectasia has become a custom. The table tries to represent all the available rings, so we have the beauty of 6 to 7 variations of arc, thickness, and optical zone, so you can correct any type of keratoconus and therefore allow for greater customization of our surgical plan. The new 2018 nomogram of the intrastromal rings allows to create a new criteria for the selection of the optical zone, implant axis, and above all, the measurement of the ring that will be implanted. It goes to fill the gap that was left by the old nomogram in 2009, so in 9 years we did not have a nomogram upgrade and only allowed us to use the 2009 version. Thanks to our Spanish colleagues, the new nomogram is finally made available to everyone. What are the data required to be able to do a surgical plan and calculate the ring to be implanted? First of all, a corneal tomography in 4 maps, an axial curvature, anterior and posterior elevation with the best fit spheres, and a pachymetric map. Naturally, it must be accompanied by an aberrometric topography with magnitude and comma axis, and obviously the surgeon must be able to determine the subjective refraction, and above all, pay attention to the correction of the maximum theoretical negative cylinder, which allows us to correct the refraction defect. We have to determine the visual acuity, whether it is with correction or without correction, the pupillary diameter in mesopic conditions, and the potential visual acuity with contact lenses or with pinhole. You need to decide which surgery technique will be used, and that is whether manual or with femto, and at the end of everything, determine which type of keratoconus we are facing according to the morphological classification of Fernandez-Vega Alfonso. The new morphological classification of keratoconus allows the implantation of intrastromal rings and is proposed by Luis Fernandez-Vega and Jose Alfonso of the University of Oviedo in Spain. Basically, there are 5 types of keratoconus that are defined by some variables. First of all, where is the cone located? Then, it is very important to understand what is the relationship among the 3 axes: flat refractive, flat topographic, and coma. Finally, it is important to understand the astigmatism, topographic orthogonality, and symmetry, and the topographic appearance of the curvature map. The first parameter to be determined is where the cone is, measuring the distance from the center of the apex of the cone on the posterior altimetric topography. It may be in a central, paracentral, or pericentral position, depending on whether it is less than 0.75, between 0.76 and 1.80, or more than 1.81 millimeters from the center. Then, you have to determine the relationships among the 3 main axes, namely the topographic, refractive, and decomatic axis. The topographic axis is the flattest axis in the anterior corneal topography. It is the one which we put the negative cylinder in, where the patient achieves the best visual acuity, and remember that the latter goes to correct the coma, because this comatic aberration that characterizes the keratoconus basically corrects itself by pretending, mimicking a comatic correction, but not having lenses to correct the coma. We correct it with a cylinder. Therefore, in a symmetrical keratoconus, the axis of the coma usually corresponds to the negative axis of the negative cylinder that we're going to correct, but not in all cases, of course. In fact, the comatic axis, which is the one that is found with the aberrometric map, is the third axis. These 3 axes can be coincident. The comatic axis may also not be coincident with the topographic and refractive axis, or the comatic axis and the refractive axis are coincident. as it often happens, but perpendicular to the topographic axis. Putting this all together, these three axes determine what kind of keratoconus we are going to have. We also have the orthogonality of the astigmatism, which means we measure the angles between the lobes of the topographic astigmatism so we can have a regular shape if the angle is below 20 degrees or an irregular one if the angle among the lobes exceeds 20 degrees. Another very important parameter to verify is the symmetry between the lobes of the topographic astigmatism. When the lobes have similar shapes, we speak of symmetry, whereas they are asymmetrical when the lobes are different in sizing. The identification of the type of ring to be implanted in the case of keratoconus of phenotype 1, called croissant, is relatively simple. We start by understanding the radius of the curvature of the cornea, so up to 52 diopters, we can use 5 millimeters. Above 52 diopters, we must use 6 millimeters. And we recommend using 6 millimeters also in patients with particularly large pupils. Always remember that the 5 millimeter ring has a flattening capacity greater than 6 millimeters, hence the choice of 5 millimeters when the curvature rays of the cornea are very high and or when the patient is very young and or when the keratoconus is very aggressive. That being said, the arc of implantation is always 160 degrees for the 5 millimeters and 150 degrees for the 6 millimeters, and this can induce a little bit of confusion, but you will soon get used to it. So we understand that the ring to be implanted is 5 or 6 millimeters. The arc is that of 150 degrees or 160 degrees. What remains to understand is what is the thickness that varies depending on the astigmatism that we have to correct. So there is an easy to interpret table that tells us that up to 2.5 diopters, 150 micron thickness is placed. Between 2.5 and 3.5, 200 microns. Between 3.5 and 4.5, 250 microns. 5 diopters of astigmatism, it takes the 300, and above the 5 diopters, it is necessary to associate the 300 microns with a 90 degrees thickness ring, 150, 200, or 250 microns of increasing thickness. The keratoconus of phenotype 2, also called duct, has the characteristic of being an asymmetric keratoconus, therefore a paracentral localization. The relationship between the topographic and comma are not coincident. The orthogonality of the astigmatism is irregular, and the astigmatism is by definition asymmetric. In this type of keratoconus, the progressive or asymmetric rings are used. Also, in this case, if the radius of the curvature of the cornea is below 52 diopters, an asymmetrical segment 160 or 2 segments is used. An asymmetric 160 plus a standard 120 in accordance with astigmatism. Obviously, if the refractive axis coincides with the topographic one, the bisector of the axis is used. If the refractive axis coincides with a comma, the bisector is used. The astigmatism determines the power of the ring. Therefore, under 4 diopters, a ring with variable power 150, 250, and between 4 and 6 diopters, 200, 300. Above 6 diopters of astigmatism, it is associated with 200, 300, and 120, 200 microns. If the keratoconus duct has a mean keratometry above 52 diopters, a new 330 degrees asymmetrical ring is used in accordance with the average curvature. Therefore, an AS5 330 degrees, 150, 250 progressive from 52 to 54 diopters of corneal curvature. Above 55 diopters, an implantation of 330, 200, 300 microns. Type 3 keratoconus, the snowman, is divided into 2 subtypes, type 3A and 3B. Both cases are either paracentral or pericentral in localization with a topographic axis and a perpendicular comma axis. The orthogonality of the axis is irregular, but they are asymmetrical. This type of keratoconus snowman has the characteristic of having to be corrected with an asymmetrical ring. The cone 3A, we distinguish it with its appearance of a snowman with a small head and big belly. Obviously, we have to do more correction in the belly area and less on the head area. Given the symmetry of the axis, it is necessary to implant two rings that embrace the snowman. However, we must distinguish if the mean keratometry is below 52 diopters. Then we implant two asymmetrical rings of 5 mm in diameter, 160 degrees of arc, and 150 to 250 microns. On the other hand, if above 4 diopters, we will implant 200, 300 microns. We have C and W, where C stands for counterclockwise and W stands for clockwise. In my mind, I try to remember that C is the thickness that runs opposite the direction of the clock. Usually, it is implanted in the right eye, so I mentally associate ring C to the right eye and W to the left eye. This is just a silly association that serves as my quick remember, but in reality, we must always understand the cone and where it is most often where we need to make more correction so as not to make a mistake of putting the wrong ring. If phenotype 3A shows a mean keratometry between 52 and 54 diopters, then it must be corrected with a 330 degrees asymmetrical ring with a variable thickness of 150 to 150 microns. If mean is above 54 diopters, then correct with a ring of 330, 200, 300. Difference with the two asymmetrical implants is reduced to a minimum because of implanting two asymmetric kissing rings. We use 330 to correct higher dioptric powers, therefore a more evolved keratoconus, because, obviously, it has more force in flattening the cornea. Finally, if we have a 3B subtype of keratoconus snowman, which is the one in which the snowman's head does not exist, there is only the belly, we use a 210. This is one of the few cases in which the 210 ring is still used. Depending on the comma we must correct, we implant a 200, 250, or 300 micron ring if the comma is below 1.5, between 1.5 and 2.5, or above 2.5 microns in the area of 5 millimeters, respectively. Therefore, the aberrometric map with the measurement of the comma is essential in this type of identification. The type 4 keratoconus, also called keratoconus nipple, has the characteristic of being spherical, so there is no astigmatism, the localization is central, there is no relation among the axes of astigmatism, and it is certainly not a determinable astigmatism. In this type of keratoconus, we have to use a 325 degrees arc ring and in diameter E65, which is also the only one available. The thickness of the ring is variable depending on the sphere that we must correct, and remember that the defect of sight of this type of keratoconus is spherical and myopic, so to correct 3 diopters, we put a 150, to correct 5 diopters, we put a 200, 7 diopters, a 250, and above 8 diopters, a 300. This is if visual acuity is determinable. If mean keratometry is 48 diopters, we put a 150 micron, for 49 diopters, a 200, 52 diopters, a 250, and over 52 diopters, a 300. Personally, I am used to thinking in diopters of visual defects, so I tend to try to measure the patient's refractive defect in the most appropriate way. Keratoconus with phenotype 5, also called bow tie, is a keratoconus whose characteristic is to present a very symmetrical small hourglass astigmatism. It has a central localization. The relationships among the axes are of the coincident type between the refractive and topographic, and the comma 1 is non-determined. The orthogonality of astigmatism is regular, and symmetry is symmetrical. In this type of keratoconus, it is obvious that we must act, above all, on the astigmatism, so we must go and implant 2 rings that embrace the small hourglass. And what are the parameters to understand which rings to implant? First of all, we need to see what the mean keratometry is. If it is below 52 diopters, a 6 mm ring can be used. If the refraction is a mixed astigmatism, it is necessary to use 2 symmetric segments of 90 degrees. If the refraction has a myopia inferior to the 2 diopters, it is necessary to use 2 symmetric segments of 120 degrees. If the refraction has a myopia of greater than 2 diopters, it is necessary to use 2 symmetric segments of 160 degrees. So, myopia has, in this type of keratoconus, a decisive role in choosing the arc. The more it is towards myopia, the more we put a complete ring. The less myopia to correct, the more we put a reduced arc ring. Therefore, the reduced arc rings correct more astigmatism, while the more complete rings correct myopia. If the astigmatism is less than 4 diopters, we put a 150. If we have to correct 5 diopters, then a 201. 7 diopters with 250, and above 8, a 300. Finally, this table determines the limits of the corneal thickness we need to implant a ring onto. It is necessary to determine the minimum thickness of the cornea in the area where we are going to create the pocket. We can do this with topography, and then we must be sure of being in a margin of safety. For example, if we want to implant a 250 micron ring, we need to be sure that we have a stromal area of our tunnel of at least 420 microns. We can recommend to customize our ring system as much as possible, to rely on competent people who can give us advice because they have implanted so many. The same company provides a website and an application to rely on. I can still give you a couple of tips when it comes to implementation. For example, use a topographer that has a ring simulation program inside. This has a shine fluke camera, or OCT, that work the same way. Then, with the software, you can create a pachymetric topographic map, outline the ring, and understand how much depth is needed, what arc to use. In short, you can put all the parameters in order to understand if you have a safety margin, the thickness of the tunnel area, and the thickness of the ring that you can implant. Always take into consideration what the bisector instrument provides you. It usually coincides with the axis of the comma, so the concept is that the ring must embrace the comma and support the ectasia, and therefore the somatic deformation of the cornea. I usually calculate with a calculator the point where we must go to make the vertical cut in the cornea to insert the ring. This vertical cut should be at least 20 degrees away from where the ring begins. So for example, if we have a 270 degrees bisector and our ring has 160 degrees, you add up to 270 degrees, 80 degrees on one side, and 80 from the other. From the temporal side, add 20 degrees again, so if it is a right eye to 270, which is the bisector, subtract 80, which makes 190. We remove 20 more, that makes 170, and then we will have to cut 270. Then our ring will have an entry in the cornea at 170 degrees. It will start at 190 degrees plus 80, which makes 270, and at 270, it will reach the bisector, so it will be the point where the belly of the ring coincides with the bisector. Add another 80 degrees, and we have the end of the ring. Then 270 plus 80 makes 350. Here is how I usually do the calculations. Another trick is to mark with the marker in the preoperative phase all these points, then the entry point and the bisector to understand where to place the ring, and never mark intraoperatively. For the majority of femtoseconds, I recommend to also mark the 0180 because the suction ring has two clicks, usually 0180, and then you can align the 0180 with the 0180 of the cup.